Is Dr. Ayalew, emergency physician. Today I'm going to talk about ECG. So we'll discuss about the basics of ECG today. So we have to look about the lead placement, the ECG paper, and we'll come upon how to read the ECG. So ECG is a graphic representation of the electrical activity of the heart. You need to know about the cardiac physiology when you go to about ECG. So there are different cells which are called pacemaker cells. So the first one is called SA node, the second one is AV node, and the third one is we'll go to the Purkinje fibers. So the first predominant pacemaker is the SA node. So the SA node will have intrinsic rate from 60 to 100. The main supply is right coronary artery, which account around 55%, whereas left circumference rest. The next one from the SA node goes to the AV nodes, and with intrinsic rate of 40 to 60 beats per minute. So it's predominantly supplied by right coronary artery. So AV node has two functions. The first one is to slow the conduction velocity, and we'll have also long refractory period. So the main predominant one is SA node. If things start from the SA node, we'll call sinus. But if it starts from the AV node or below, at the junction, we call it junctional rhythm. And then the rhythm below that, that means from the fibers, then it becomes a ventricular rhythm with a rate of like 20 to 40. So after the SA node, it goes to AV node, then to the bundle of his. After that, to the right and the left bundle. With the right and left bundling will be divided into left anterior and left posterior fascicle. So during the normal cardiac conduction, the electrical cells will be polarized. When there is an excess sodium entry to the cell, they become depolarized. So the pacemaker will initiate impulse from the SA node, and then it passes to AV node, and it goes to the Purkinje fiber, then to the contractile muscles. So what do we see on ECG? So the things we see are three things. The one is waves, the second is segments, and the third one is intervals. So what is wave then? So anything with upward or downward deflections are called waves. So based on this, we have P wave, we have QRS complex, we have T wave, and also U wave. When you say segments, all those flat lines are called segments. So this happens because there is no electrical difference. So this is a flat line. The first flat line is a PR segment. And then the second one is ST segment, and the third one is TP segment. So the one which is really important, the PR or ST segments, that we have to discuss later. The other one is the interval. So the first, which contains P waves within segments, is called PR interval. So PR interval includes the P wave and the PR segment, whereas the QT interval contains the QRS complex, the T wave, and the ST segment. So what is P wave then? So P wave is the indicator of the activation of the atrium or the atrial depolarization, whereas the QRS is a ventricular depolarization, and T wave is ventricular repolarization. So how do you get this? How do you get this ECG? So use different leads. We have 12 leads and 15 leads. So the 12 leads has 6 limb leads and 6 pericordial leads. So the 6 limb leads, the main one is 3. Lead 1, lead 2, and lead 3. The rest 3 are augmented leads that augment the voltage of those limb leads. So how do you get the limb leads? Is by attaching to the hands and the legs. So you need to check the labelings of your ECG machine, the cables. So those labeled R will go to the right arm. Those labeled as L will go to the left arm. And which labeled as F will go to the foot of the left side, and N, or the black one, will go to the right leg. So what makes lead 1 is the connection between the right arm and the left arm. And the connection between right arm and left foot will give you lead 2. Whereas left arm with the foot will give you lead 3. So anything perpendicular to these leads is called augmented leads. So what is perpendicular to lead 1 is AVF. Okay? And what is perpendicular to lead 2 is AVL, and what is perpendicular to lead 3 is AVR. So these are the 6 periods. The rest is the chest leads or the pericordial leads, which is containing from V1 to V6. So you place V1 in the right sternal margin on the fourth intercostal space. So you need to count the intercostal space, and you place parasternal on the fourth, the V1 and V2 on the left, on the right, the left side, the same level. Then you place V4, the left mid-clavicular line, fifth intercostal space. So you go back and you put V3 between V2 and V4. Then V5, you continue anterior axillary, V6, mid-axillary line, the same level on fifth intercostal space. So to make 15 leads, you may need to move the V4 on the left side to go to the right side, which is called V4R, to look for the right side. If there is a RV involvement, you may need to move V4 to the right side. And for V8 and V9, you go same level as V6, but V8 in the scapular tip and V9 lateral to the spine. These are used to check for posterior side of the heart. Lead 2, 3, and AV, it tells you about the inferior. Lead 1, V5, V6 will tell you about the lateral. V1 to V4 tells you anteroseptal. V8 and V9 will tell you about the posterior side of the heart. So now let's see about the ECG paper. So the ECG paper, the tracing will be recorded on horizontal and vertical axis. So the horizontal axis represent time, whereas the vertical axis represent voltage. So when the depolarization moves in the direction of the leads, it becomes a positive deflection. Whereas if the vector travels away from the lead, and then it becomes a negative deflection. So we usually use a speed of 25 and 25 millimeter per second to print the ECG. So the ECG paper has a large square and inside a small squares. So one large square is 0.2 second, whereas one large square, the height is 5 millimeter. So each small square is 0.04 second. And each voltage is 1 millimeter or 0.1 millivolt. Okay, so now let's see the components of the ECG that we were saying earlier. So waves, first one, the first wave is P wave, which tells you depolarization of the atrium. If any problem happens here, it tells you the problem of the atrium. So P wave represents the summation of the depolarization of the both and the right atrium and the left atrium. The normal scenario, there will be one except the lead B1, which it becomes biphasic. So the next one is QRS complex. So it tells you ventricular depolarization. So the normal QRS duration is 0.12 seconds, or should be less than 3 small box. So Q wave is the first initial negative deflection, whereas R wave is the first positive deflection, and S is second negative deflection. So not all QRS complex have all three components. So the duration of the QRS is measured from the beginning of the Q and the end of S wave. And the end of S wave, the beginning of ST segment is called J point. The next wave is T wave, which tells you about the repolarization of the ventricles. And sometimes I will have U wave, where the origin is uncertain and could be seen in a patient with hypokalemia. Interval, PR interval represent the conduction delay from the AV node, which the normal is should be less than 5 small box or 0.2 second. And QT interval is the whole duration of the ventricular depolarization and repolarization. So the end of T wave should be less than halfway the RR. So to say, then QT is in the normal. When you say segments, we talk about segment elevation or depression. So, but we mostly worried about the ST segment. So the ST segment begins with the J point, which is level in the brain, and usually is isoelectric in reference to the TP segment. So if there is elevation of the J point in reference to the TP segment, it's called ST elevation. If it is below the reference point, then it's called ST depression. So now let's go to the basics of ECG interpretation. Just the main ones. Anyone, whether you're a nurse or general practitioner, so at least know 4 things. But for the others, you need to go in details. Maybe we'll do another session about the detailed interpretation. But at least know this 4. So what is a rhythm? What is rate? What is segments? And about the interval. Okay. So if you know these 4 basics, at least you can diagnose some problems. So when you say rhythm, look for the rhythm strip, the first one, whether it's on the monitor or the ECG paper, you check for the full length. So you look for, is it sinus or not? So to say sinus, there should be P wave, and the P wave should be followed by the QRS, and the QRS should be preceded by P wave. And it should be regular. So if it's sinus, call it a normal sinus rhythm. If it's sinus, but it's irregular, then it's sinus arrhythmia. So the normal P wave axis should be positive in lead 1 and ABF. And the QRS should be narrow. So anything which is no sinus is called arrhythmia. As you see here, there is no P wave and it's not sinus. And it's irregular. So it's commonly known as atrial fibrillation. And the next one, see, no P wave, but it's wide QRS, regular. So this is called ventricular tachycardia. The next one is you need to calculate the rate. So the rate in the normal condition should be 60 to 100. So if you know that it's sinus or it's regular, then next, if you know this is regular, you calculate by dividing this 300 to the number of large box. So you check between 2 RRs and how many large boxes are here. 1, 2, 3, 4, 5. So we have 5 large box, so 300 over 5, it will be 60. This works if the ECG or if the RR interval is regular. So if it varies, if it is become regular, you need to count the number of RR intervals and you multiply by 6. So the ECG should be done in 10 seconds. So you can calculate the rate for this. The next one is QRS. So QRS, it tells you about a ventricle. So one is the duration. So it could be narrow when it is less than 3 small box. If it is wide, there are many causes for wide QRS. The next is voltage, could be high voltage or low voltage based on a voltage criteria. So the segment, ST segment, PR segments, and TP segment. You check for ST elevation, ST depression, in reference to the TP segment. The QT interval should be less than 0.45. When there is a prolonged QT, could be because of hypokalemia, hypocalcemia, or hypothermia. But the risk is dorsal pointers or arrhythmia. So you check for the RR interval, and then the end of T wave should be less than 50% of the RR. But if it passes 50% of the RR, it causes QT prolongation. So, in summary, you check for the rhythm, whether it's regular or regular, whether it is sinus or not, whether it is narrow QRS or wide QRS. Then the rates, is it slow, is it normal, or is it fast? And the segment, is there ST elevation or ST depression? Is there QT prolongation, PR prolongation? So these are the things that you have to look. The detailed interpretation will be proceeded in the next sessions. Thank you.